Okay, so the first specimen is coming from a 63-year-old female. She presented with some neurological signs and came to our hospital. So through image study, they were suspicious lesion in the brain that was suspicious for metastasis. So the patient received CSF taping. So I think the patient developed some like a high pressure, intracranial pressure. So she also probably received peritoneal shunt, ventricular peritoneal shunt. So in this specimen, you can actually see some brain tissue. So here we identify fragments of these glial tissue. So these are astrocytes, and here are some glial tissue. So additionally, the patient also received image study that identified there is lung lesion and suspect to have lung cancer. But due to her condition is not suitable for lung biopsy, she only received a liquid biopsy. So this is getting somewhat more common nowadays. In the usual scenario, we would expect the patient had a tissue proof to confirm the original tumor, and then there is metastasis. But nowadays, the patients only have CSF specimen and require us to confirm that this is coming from the lung. And she also received a liquid biopsy for molecular testing, and it already came back with a EGFR mutation. So nowadays, getting more and more common that the patient had a mutation confirmed, had an image confirmed, but without having any tissue proof. It is not recommending in our insurance, but and I think likely the patient would need to receive the medication by self-pay because our insurance required to have a tissue proof. But because of her condition, she decided not to receive the biopsy. So when we interpret the CSF specimen, we realize that usually there's no cells at all. And if we identify some cell, it must be some problem. It can be inflammatory process, it can be neoplastic process. So I just want to show you that for the metastatic adenocarcinoma in the CSF, usually it is quite bland looking with perfectly rounded nucleus, and a lot of time it will only show single cell without cluster. So this is pretty much that we have. So we also have a direct, like a pap smear, alcohol fixed pap smear, and we recover the cover slide and we perform the TTF1. So TTF1 highlights these individual cells which are positive in the nucleus. So these are metastatic adenocarcinoma coming from the lung, and with only like 3-4 cells, and we need to confirm the diagnosis. So nowadays the specimen is getting scanned, and they require more information from us. So the next specimen is a 62-year-old female. This is coming from the ascites. So on low power, it is hypercellular. We do not see a lot of like aggregates of the tumor of the cells. There's one over here, another one over here. So usually when we screen these, this is the area that we want to go to higher power. So when we go to higher power, indeed, this is a very tight aggregate with three-dimensional architecture. However, you can appreciate that the cell seems to be quite uniform. Most of them were rounded with a similar size. But in the background, the individual cell looks funny, right? So it looks like they will all have these eccentric nucleus showing a signaling cell-like morphology. So the patient actually had a history of gastric cancer with signaling cell adenocarcinoma. So in the background, you see most of these relatively bland-looking individual cells. These are actually tumor cells. And this one is likely a mesothelial cluster, so it's totally reversed from our ordinary impression of body fluid cytology. Again, here these larger aggregates, we do see some inflammatory cell infiltrate, but most of these cells are rounded with a similar size, so this is likely the mesothelial cluster. And here you can see in the cytoplasm, it seems to be mucin material pushing the nucleus away. So most of the individual cells are actually signaling cell carcinoma. So the specimen is positive for adenocarcinoma. So history is kind of important, but the cytomorphology is also important because when we see a body fluid specimen, we rarely see in the background cell showing this prominent signaling cell morphology. So these are actually cancer cells. So this is positive for metastatic adenocarcinoma and consistent with the patient's history of gastric adenocarcinoma. So let's move to some final aspiration. Before that, we have some more body fluid. So the first one is a 75-year-old male, ascites specimen. He had a history of pancreas cancer, pancreatic adenocarcinoma. So this is ascites fluid, so mostly single cell, and we are looking for what we call the second population. So we do identify some cluster of cells. So for pancreatic cancer in the body fluid, they were usually very tight and small aggregates forming a small cluster or tubular architecture. And if it is well differentiated, sometimes the nuclear polymorphism is not very striking. So you can appreciate that there are actually some cells in the background. This is a mesothelial cell with binucleation, mesothelial cell, mesothelial cell. These cells actually has bigger nucleus than the tumor cell. But the key point is that it is a tight aggregate. And also here we do see some oranginophilic material in the cytoplasm. So these are mucin production. So this is actually metastatic adenocarcinoma, cytomorphologically consistent with a pancreatic cancer. So for the pancreatic cancer, they were well differentiated or poorly differentiated. So for the poorly differentiated cases, you won't have many problems because those will show striking nuclear atypia. But for the well differentiated, sometimes kind of problematic because usually they only form very tight, small cluster, and sometimes the cell doesn't show prominent atypia. So here we do see a more polymorphic cluster and with a unusually bubbly cytoplasm. So this is also a cluster of adenocarcinoma. So let's go to this cluster. So these clusters do show more hyperchromasia in the chromatin comparing to the adjacent normal cells. And here you also see very scant orogenophilic material in the cytoplasm, so this is mucin. So the cluster arranged in a very tight, like a tubular structure. And here you even see a mitosis. So this is positive for adenocarcinoma and consistent with the permeatobiliary origin. So the next specimen coming from a 72-year-old male with unknown, like a primary origin. So he presented with abdominal fullness and came to our emergency department. So in this specimen, low power, we already see very tight and dark cluster. So these are likely problematic. So we go to higher power. So indeed, the arrangement is not normal, and if you looking at the edges of this cluster, and you can identify the cell do show more vesicular chromatin and prominent nucleoli with some polymorphism. So this is consistent with metastatic adenocarcinoma. And here is a smaller cluster, but you can appreciate the shape of the nucleoli are very bizarre and cherry red. So again, here you see a much bigger cell with prominent nucleoli. So these are consistent with metastatic adenocarcinoma, but the patient doesn't have any primary like a history, and he is a male. So if the patient is a female, the most common scenario for this situation is coming from the gynecologic organ. So for the male, it is likely coming from the GI tract. So here you can appreciate a more tight cluster, and it seems to be that in the cytoplasm they may have some mucin material. So these might be a GI tract adenocarcinoma with peritoneal carcinomatosis. We don't have a cell block for this case, so we won't be able to do additional study. But because of these positive findings, the clinician can continue the workup of this case. So for needle aspiration, okay, so the first case is a parotid aspiration. So this is coming from the parotid gland. This is a liquid-based specimen. So in the background, we do see some aggregates of the cells, but also individual cells in the background. The cell looks pretty small. So when we go to higher power, we can confirm that these individual cells in the background seems to be inflammatory cells. They are some lymphocytes, some plasma cells, and a little bit of PMM. So these aggregates seems to be lymphocyte with crashing artifact. So this is lymphocytic tangle. And here we do see a relatively normal looking acinar cell cluster. So these are non-neoplastic acinar cells, which prove that the needle is inside the parotid gland because we have this normal component. So we have a lymphocytic background with sort of like a necrotic debris material. And then we start to see the cluster of epithelial cells with oncocytic feature. So these are flattened oncocytes. So the combination with a lymphocytic background stroma with a little bit necrotic like a degenerative debris plus the presence of benign looking, like a very flattened, larger sheets of oncocytic cells. So these equal to Warthin tumor. So this is a benign Warthin tumor. And the Warthin tumor is almost exclusively arising in the parotid gland. So the location is also good. So this is also a non-neoplastic S inner cell cluster. So pay attention to the arrangement and the cytoplasm, which looks different from the neoplastic oncocyte. So this is a benign Warthin tumor. So the next case is coming from the thyroid. So this is the thyroid aspiration. So in the background, we don't see a lot of cells. We see scant mucin, scant colloid, and it seems to be some histiocyte in the background. So it seems to be a cystic background with a little bit of colloid, and the histiocyte also like confirm that it is a cystic lesion. So whenever we encounter these type of cystic change, we need to confirm that whether there is any epithelial cells in the background before we jump to the conclusion that it is a hemorrhagic cyst. So here, this is multinucleated giant cells with bubbly cytoplasm. So pay attention to the background. We actually do not see a lot of blood, only cystic fluid and some colloid. So then we start to identify some cluster of epithelial cells. So this architecture that I would call, this is actually a decapitated papilla. So what is a decapitated papilla is that when you see the cellular fragments, you can see on three sides of these fragments, they are luminal border. And on one side of these fragment, it is blunted. So this is the decapitated site. So this is actually a papillary structure. So you can appreciate this is papillary structure, and the cells do show some elongation. So this actually looks like a papillary thyroid carcinoma. So this is a very pulsy cellular specimen with a cystic change. So this is actually suspicious for a papillary carcinoma with cystic change. So if you take a look of the background, and you can start to appreciate that there might be some cell showing more prominent feature of PTC. So we do see an intranuclear pseudo inclusion here. So because of the scan cellularity, and the lesion is actually quite small, it's smaller than 1 centimeter, we were going to use suspicious category. So we will call this suspicious for cystic PTC. Yeah, so if we have more material, we might be able to directly call it, but I think for this case, suspicious is fine because we only have 2 clusters of cells. But just pay attention to the background. And this is very important. If you see the background is not very hemorrhagic, you do see some colloid, some histiocyte, then you need to check the morphology of the epithelial cell that you can find. And if you find papillary structure and with some degrees of nuclear atypia, you need to think about the possibility of a cystic PTC. So this is a good case of a cystic PTC, and we are going to sign this out as suspicious for papillary thyroid carcinoma. So the next specimen is also a thyroid aspiration specimen. So in the background, it seems to be some material, uncertain whether this is colloid or these are blood. We do see some more dense colloid. So we have some scant dense colloid here and there. The specimen, this is a direct smear, is quite cellular. And when you take a look of this cellular cluster, you can appreciate that most of them have abundant granular cytoplasm in large nucleus, so these are all oncocytes. So we have oncocyte-rich aspiration with relatively scant colloid, and additionally, I think some of these epithelial cluster does show some vasculature. So when we encounter oncocyte-rich aspiration, we will usually pay attention to the background. If the background is very clean with minimal colloid, we will consider to call these suspicious for oncocytic tumor. So here you can appreciate that there are some vasculature, like a meshwork within these larger fragments of oncocyte. So if it shows some like lymphocytic background, you may want to consider this is just lymphocytic thyroiditis and with focal oncocytic change. If you see a lot of colloid, you may want to consider that this is actually a follicular nodular disease with oncocytic change because there are a lot of colloid. So there are something in the middle. So this is one case that you do see more oncocyte and less colloid, and most of the colloid are quite dense type of colloid. So this is something that in between. So we might consider to call these AUS with oncocytic aspirate. But before that, I just want to check what is the gross finding. So it turned out to be that it is a very big nodule, and it also shows peripheral hypervascularity. So the gross image, the sonal finding, it actually looks much like a tumor instead of it is just a goiter. So finally, we decided to call this case TBS4, suspicious for follicular neoplasm oncocytic type. Yeah, so this is the correlation between the morphology and the gross finding. So finally, there is a relatively difficult pap smear. So the patient has history of low seal, biopsy confirmed like 5 years ago, and in between she was followed up in our hospital with multiple ascus. So she's younger than me. Okay, so so you can appreciate we do have a lot of superficial cells, so, which means that she's young. We have nice cluster of endocervical cells here, so the sampling area is okay. So let's take a look at this area first. That this is one of the more problematic area that you see the smearing direction, and we do see some intermediate cells with funny like a cytoplasmic like a process. The cell does not show like a striking increase of the NC ratio, but the chromatin pattern seems to be more hyperchromatic than usual. And through the smearing direction, you can appreciate that these cells looks funny with a little bit coarse chromatin. And this is like a more mature squamous cells with a nuclear atypia. We have some binucleation here, but there's no definite coilosity change. So here is another like a similar foci that we have a more like a pycnotic, like a shrinkage cells with a more prominent like a spindle, unusual like a elongation and spindling through the smearing direction. So we've encountered a few cases that we are initially unable to call the upfront as high CO, and through the biopsy, we realized the biopsy is showing a more mature type of high CO, with superficial cell showing more maturation than the usual high NC ratio that you would expect to see in usual type of HPV positive high CO lesion. So sometimes with the superficial smearing, this is what we have only. So I think at least we should call these ASCUS high, right? Because of this degree of hyperchromasia, but without the striking increase of NC ratio. So I think initially we should call these ASCUS highs, but because of the prolonged history of ASCUS, and she does has a prior biopsy proven to be low CO. So this is also a pycnotic squamous cells. It's making like a diagnosis only based on these cells is dangerous. But because throughout the entire specimen we can identify areas showing this degree of like a nuclear change atypia. So I think maybe it's okay that we call these high CO. So Dr. Shi agreed to call these CIN2. I think CIN2 is okay. Maybe it's because she has been followed for 3 years with all the ASCUS diagnosis. Maybe it's a time for her to get the colposcopy examination. Yeah, so for this case, I think we pushing the diagnosis from ASCUS to CIN2 just to ask the clinician to check the patient with colposcopy. So I personally think these type of cells are really problematic because sometimes it's only just a reactive type of change, but we start to find that in our correlation, many of these cases are actually turned out to be high CO, but with a mature type of high CO, so the superficial smearing can only identify these atypical looking spindle cell. So with the old criteria, that is very difficult for us to call these high CO. But I think, yeah, for this case, it is likely a high CO because the patient do have evidence of prolonged HPV infection. So, so let's call this CIN2 and check the colposcopic finding to check the patient if she has indeed a high CO. Yeah, so there is another cluster with these dark superficial cells, increased NC ratio, but lacking the typical feature of high CO. So I would say after the vaccination and when the HPV rate is getting down and we are have this difficulty for routine pap smear because the CO lesion actually doesn't look like it used to be. Like it used to to be very easy. When you see a high CO, it's easy. But nowadays, it's getting more and more difficult. Sometimes it's because the clinician didn't sample the lesion right, and sometimes it's because of the nature. Maybe this is not a P16 and like other high risk, and we show these more like a mature type of morphological pattern. So okay, so that's for other case today.